Hi there. In this tape we'll be looking at the biomechanical assessment and treatment of the lower limb, and we'll be beginning with stress testing of the ankle ligaments, the collateral ligaments of the ankle. So looking at the lateral side of the ankle, for the anterior talar fibular joint I want to grasp the talus in a fairly wide grip and the crucis to stabilise this, and then I'll plantar-flex the talus, invert the talus and then stress it by adducting. For the calcaneofibular ligament, we'll bring the foot up into some dorsiflexion. We don't have to be fanatical about this, but some dorsiflexion, particularly by pulling the heel forwards, and then invert the heel and again stress it by adducting. For the posterior talar fibular ligament, we'll have the patient lying prone, and this is about the easiest way to do it, not the only means by any means, but the easiest. And we'll stabilise the crucis and the fibula. Now this ligament is running horizontal across this direction, so in order to stress this I will try to laterally rotate the foot on the leg, and this will take the talar attachment away from the fibular attachment. So I'll stabilise the fibula by bringing my thumb against the posterior aspect of the malleolus and hold the whole leg into medial rotation. Come down, grasp the calcaneus and the midfoot, and then twist as if it was a top on a jar with the foot in full dorsiflexion. Come back onto your back for me. For the medial collateral ligaments, we'll be doing mostly an eversion manoeuvre. For the anterior ligaments, the superficial part, we'll grab hold of the navicular, stabilise the crucis, come just a little from, thank you. Plantar-flex the navicular, evert, and then abduct. This will test the superficial part of this ligament. To test the deep part, which is attached to the talus, come onto the talus now, plantar-flex that, evert and adduct the talus. So it's a slight change in the position of the moving hand. For the superficial part of the middle fibres of the deltoid, these are attaching to the sustentaculum. We'll come onto the sustentaculum with the heel of the hand there, dorsiflex the foot like so, evert the heel by pushing through the sustentaculum and then abducting. To come up onto the talus, the deeper fibres now, we'll just move up from the sustentaculum onto the talus in the same position and do exactly the same thing, eversion and abduction, eversion and then abducting. For the posterior fibres on the calcaneus, come behind and below the malleolus, so you're directly on the calcaneus here. Dorsiflex the ankle again, and this time we will evert the heel, but the abduction force will be somewhat more oblique, coming rather dorsally than straight laterally in this direction there. And again, to pick up the deep fibres, we'll move behind the medial malleolus onto the talar tubercle here and do the same thing on that bone itself. We can, of course, use the draw test for the anterior parts of both of these ligaments. And in this case, the leg will be brought up into a flexed position, the ankle in its resting position here, and then stabilise the foot and push the crucis backwards, which of course is a relative anterior translation of the talus. And for a positive test here, we're looking for medial or lateral rotation of the leg as we draw it, push it backwards. If it laterally rotates, then we have possibly a problem and a deficiency in the lateral ligament. If it medially rotates, the medial ligament. Intimate with the ankle joint itself, of course, is the inferior tib-fib joint, and this needs to be stressed. This is often injured with inversion injuries. So there are a couple of different ways of stressing this. We can put the foot into its fully dorsiflexed position here, making sure that it is fully dorsiflexed, and then we can draw the crucis forwards on the talus. Now in this position we're actually trying to jam the wide part of the wedge onto the mortise, and it shouldn't move. There should be bony stability. So any movement here is indicative of instability. Another method of testing this is to shear the fibula laterally. And to do this, we'll have the patient lay on their side, come down the bed, so that about half of the leg is overhanging the edge of the bed. Stabilise the leg onto the bed here, come onto the talus, the medial side of the talus, just below the malleolus, and push down. If this ligament's intact, then you'll get a nice solid capsular end fill. If it isn't, then you'll actually bend the fibula away from the tibia slightly, and the end fill will be more springy. Having stability tested the ankle, we can now look at its mobility. And remembering the biomechanics of the ankle, the talus is a convex surface for plantar flexion and dorsiflexion. So we're looking to assess a dorsal glide for dorsiflexion and an anterior glide for plantar flexion. And with the following tests, the Taylor swing test, we can assess both the physiological and the arthrokinematic movements simultaneously. So we'll have the patient sitting up and bring the chair around this position and get yourself comfortable. We will palpate the medial tubercle on the talus around the medial malleolus and put the thumb onto the neck of the talus anteriorly. The other hand, the index finger, will come around the back of the fibula and the other thumb over the palpating thumb. And then we're going to swing the leg backwards and forwards underneath the bed, making sure that the ankle goes through its full range of plantar flexion and dorsiflexion as we do so. So it's simply a swing back and a swing forward. And as we do this, we assess both the range of physiological movement. We also assess the ability of the talus to glide, and by palpating the tubercle on the talus, we can also assess its conjunct rotation as we do this. This technique can also be used for treatment. Now, we should have an adequate idea of which mobilities are compromised here. So we can treat using this glide. For example, to regain dorsiflexion, I shall keep my hands in the same position, take the leg back as far as it'll go under the table. I'll use the hold relax technique. Don't let me lift your foot up, and relax. And as she relaxes, I'll just take it into a bit more dorsiflexion. I can oscillate using the grade 4 oscillation, and then to mobilize, I'll emphasize the lateral conjunct rotation by twisting the foot laterally and pushing it further under the bed. So I will mobilize dorsiflexion in that way. For plantar flexion, I'll swing the leg towards me, do the hold relax techniques again, don't let me move you, and relax, take up more plantar flexion, and then basically increase the conjunct rotation and pull the talus towards me. These techniques will be more than adequate on the vast majority of your patients. There are a couple of other techniques that you can use when you have a particularly stiff ankle or a particularly painful one. Could you lay back for me? For these, we'll need a sandbag to stabilize the foot. So again, to bring the talus into plantar flexion, we will need to do a ventral glide of the talus. Now, there's a couple of ways we can do this. Probably the easiest way is to simply move up the bed a tad for me, Bibi. Stabilize the heel on a sandbag, put the patient into the conjunct rotation and the barrier. So we'll plantar flex them and medially rotate the talus, and then come in and glide the cruis backwards, thereby inducing a relative anterior glide of the talus to mobilize plantar flexion. For dorsiflexion, where we need a dorsal glide, we can do it over the edge of the bed. So we bring the patient into this position, a little bit more down. Good. Stabilize the cruis now. There. Dorsiflex the ankle and glide backwards this way. An alternative technique, which is maybe a little easier, is to bring the patient into this position, as far into dorsiflexion as they can go, emphasize the lateral rotation, and then draw the cruis forwards on the stabilized talus, again inducing a posterior glide, or at least a relative posterior glide of the talus to increase dorsiflexion.